Hi everyone. In this lesson, I'm going to talk about iron deficiency anemia in children. The content of the discussion contains introduction, etiology, clinical manifestation, laboratory findings, differential diagnosis, prevention, treatment, and the follow-up of iron deficiency anemia. As an introduction, iron deficiency is the most widespread and the common nutritional disorder in the world. It is estimated that 30 to 50% of the global population has iron deficiency anemia. A term newborn infant contains about 0.5 gram of iron compared to 5 gram of iron in adults. This means that an average of 0.8 milligram of iron must be absorbed daily during the first 15 years of life. Therefore, it is necessary to absorb around 1 milligram of daily iron to maintain positive iron balance. Because less than 10% of dietary iron is usually absorbed, a dietary intake of 8 to 10 milligram of iron daily is necessary to maintain iron levels. Most iron in neonates is in the circulating hemoglobin. Due to the because erythropoiesis is everywhere during the neonatal period, during the intrauterine period, erythropoiesis is everywhere. There is a relatively high concentration of RBC and also high concentration of hemoglobin level in newborn. This high hemoglobin concentration of the newborn infant falls during the first 2 to 3 months of life. Then there is considerable iron will be recycled. These iron stores are usually sufficient for the bread formation in the first 6 to 9 months of life in term infants. But stores are depleted sooner in premature infants, in low birth weight infants, or infants with perinatal breakthroughs because their iron stores are smaller. Delayed clamping of umbilical cord can improve iron status and reduce the risk of iron deficiency in early childhood, whereas early clamping, that means less than 30 seconds, puts the infant at risk for iron deficiency anemia. So, as much as possible, delayed clamping of umbilical cord is important, and we should have to delay the cutting of umbilical cord for at least 1 to 3 minutes to increase the iron store of the body of the child. When we came to the etiology of iron deficiency anemia, etiology we can classify to two: decrease the supply of iron and also increase distraction or increase the loss of iron. When we see decreased supply, the first and the most common cause is inadequate dietary intake of iron. Nutritional iron deficiency is usually due at the age of 9 to 24 months of age, because up to 9 months of age, the recycled iron from the high hemoglobin concentration during the neonatal and intrauterine period is adequate to make erythropoiesis available. Excessive consumption of cow milk. Cow milk have low iron content, and also bread loss from milk protein collates causes inadequate availability of iron for production of red blood cell. Worldwide, undernutrition is the most common cause of iron deficiency. Gastric bypass procedures or H. pylori infection may interfere with iron absorption because iron is absorbed in the proximal duodenum with assistance of gastric acids, and lack of gastric acid predisposes for iron deficiency. The other cause for iron deficiency is increased loss. Increased loss can be from anything that causes loss of the iron. For example, in adolescent girl, menstrual losses can cause iron deficiency anemia, recurrent nosebleed, recurrent epistaxis, intravascular hemolysis with hemoglobinuria, for example, in disease like malaria or hemolytic disease. Occult bleeding may be caused by lesions of the gastrointestinal tract, such as peptic ulcer, Meckel diverticulum, polyp, hemangioma, IBD or inflammatory bowel disease. Exposure to whole cow milk protein, which causes milk protein collates, causes occult bleeding, and it may predispose for iron deficiency anemia. In developing country like us, infection with hookworm, trichuris, trichuria, and plasmodium also contributes to iron deficiency anemia. Pulmonary hemosiderosis can also cause iron deficiency anemia. When we came to the clinical manifestation of iron deficiency anemia, most children with iron deficiency anemia are asymptomatic. So most of them are diagnosed during the routine screening with hemoglobin and hematocrit at the age of 9 to 12 months. If the child becomes symptomatic, progressive pallor, which involves the palms, palmar creases, nail beds, and the conjunctiva will appear slowly. Later, if the anemia progresses, cold intolerance, fatigue, exercise induced dyspnea, decreased mental acuity will appear. and also irritability, anorexia, lethargy, and slow systolic flow murmur can be heard. If the anemia becomes more severe, the systolic flow murmur may progress to tachycardia and also high output cardiac failure. And also, child with iron deficiency may have PICA. PICA means increased appetite, increased interest to eat non-nutritive substances. And also they might show pacophagia, which means increased interest to eat ice. Iron deficiency has also non-hematologic systemic effects. Both iron deficiency and also iron deficiency anemia can cause impaired neurocognitive function in infancy. Iron deficiency anemia can cause possible irreversible cognitive defect. There is also some studies shows there is increased risk of seizure, strokes, breath holding spells, and the like in children with iron deficiency and also iron deficiency. When we came to laboratory finding, in progressive iron deficiency, a sequence of biochemical and hematologic events occur. First, tissue iron stores are depleted. These tissue iron stores are depleted and it is manifested in the form of reduced serum ferritin. This serum ferritin is an iron storage protein which provides an estimate of body iron stores in the absence of inflammatory disease. Because ferritin is a sign of it rises during acute inflammation, because it is an acute inflammatory substance, it rises during inflammation. So during inflammation it might falsely rise. So reduced serum ferritin in the absence of inflammatory disease shows reduced iron stores. Next to tissue iron stores, after tissue iron stores are depleted, next serum iron levels decrease. Then iron binding capacity of the serum or serum transferrin increases, and also then transferrin saturation falls below normal. Later, iron becomes unavailable to complex with protoporphyrin to form heme. So there is increased free erythrocyte protoporphyrin accumulates. Then hemoglobin synthesis impaired and iron deficiency anemia progress to iron deficiency anemia. Hemoglobin level. Hemoglobin is low in all anemia. MCV is decreased in both iron deficiency anemia and also thalassemia. And in anemia of chronic disease, there might be also low MCV. RDW is increased in iron deficiency anemia, whereas it's normal or increased in thalassemia, and it's normal in anemia of chronic disease. RBC count is decreased in iron deficiency anemia, whereas it is normal or increased in thalassemia, and also it's normal or decreased in anemia of chronic disease. We can also do serum ferritin level or total iron binding capacity, transferrin saturation, and the like to differentiate the differential diagnosis from it. In order to prevent iron deficiency anemia, iron deficiency it should be prevented to avoid both its systemic manifestation and also from its hematologic manifestation. The first thing is breastfeeding. Breastfeeding with addition of supplemental iron at 4 months of age. Up to 4 months, there is adequate store of iron from the recycled iron during the decrement in hemoglobin concentration of which is high during the after delivery. So breastfeeding is adequate for 4 months, and after that breastfeeding should be supplemented with iron. Infants who are not breastfeeding should only receive iron fortified formula during their first year of life. So during the first year of life, if there is no breastfeeding, they should have to take iron fortified formula, around 12 milligram of iron per liter. Breast milk and also cow milk have low amount of iron, around 1 milligram per liter, which makes them not adequate for the daily requirement of iron of a child less than 1 year of age. And also we should have to avoid cow milk during the first years of life, because cow milk it can cause cow milk protein colites, and also cow milk have low amount of iron, as we have said, around 1 milligram per liter of water, 1 milligram per liter of milk. And also cow milk have high concentration of calcium, and the calcium causes it inhibits iron absorption. So cow milk have high calcium, which inhibits iron absorption. And also cow milk causes cow milk protein collides, and also cow milk have low amount of iron. So cow milk is not recommended during the first years of life. Thereafter, cow milk should be limited to less than 20 to 24 hours per day, around 700 ml per day. We should have to give less than that. Youth screening for all children using hemoglobin and hematocrit is done at age 9 to 12 months. When it comes to treatment, the regular response of iron deficiency anemia to adequate amount of iron is a critical diagnostic and also therapeutic feature. Normally, calcium and fiber may decrease the absorption of iron, and also when we give iron, tea also significantly inhibits the absorption of iron, so we should not give iron with tea. And also we should have to decrease fiber and the calcium during iron supplementation or iron treatment. A daily total dose of 3 to 6 mg per kg of elemental iron in 1 to 2 doses is adequate. Blood transfusion most of the times not needed, almost not needed. It should only be used when heart failure is imminent or if the anemia is severe with evidence of substantial ongoing blood loss. Iron therapy may increase the virulence of malaria and also certain gram-negative bacteria. So it's better to delay the administration of iron or iron therapy if a patient has active malaria or if patient have gram-negative infection or gram-negative sepsis. We can treat the malaria or gram-negative bacterial infection first, and we can supplement iron therapy later. Iron overdose is associated with Yersinia infection, so we should have to avoid iron overdose. We should have to appropriately calculate amount of iron, 3 to 6 mg per kg per day of elemental iron in 1 to 2 divided doses. In addition to iron therapy, dietary counseling is also necessary. Excessive intake of milk, particularly cow milk, should be limited. Dietary iron should also be increased. Iron from heme source is 10 times more bioavailable than from non-heme source. That means iron which we get from meats and animal products are heme source, heme iron, and that is 10 times more bioavailable and more absorbable than that of non-heme source, source which we get from plants and plant products. When we see the follow-up, if iron deficiency anemia is mild, repeating the blood count 1 month after initiating therapies, it's enough. At this time, either the anemia is already corrected or hemoglobin increased at least by 1 to 2 gram per deciliter. Or if the anemia is severe and if we want to make sure the anemia is iron deficiency anemia, we can check reticulocytosis after 5 to 7 days of starting iron treatment. Iron medication should be continued for 2 to 3 months after blood values normalize, just to re-establish iron stores in the. Don't forget to like and subscribe, and also thank you for listening. And then you can listen my previous video about approach to a child with anemia overall. Thank you.